From the American Neurological Association, I'm Adeline Goss. This is ANA Investigates. There has been tremendous progress in recent decades in the management of ischemic strokes. Meanwhile, hemorrhagic strokes have stubbornly resisted this progress. Interventions for these types of strokes have failed again and again to show a benefit over standard medical management. Until this year. The recently published ENRICH trial is the first to show that minimally invasive neurosurgery may improve functional outcomes for patients with hemorrhagic stroke. Study lead author Dr. Gustavo Pradilla joins us today to talk about differences between ENRICH and previous negative trials and future neurosurgical approaches for spontaneous intracerebral hemorrhage. Dr. Pradilla is a professor of neurosurgery, otolaryngology, and head and neck surgery at Emory University School of Medicine and chief of neurosurgery at Grady Memorial Hospital. He spoke to ANA producer Dr. Masoom J. Desai, neurointensivist and Assistant Professor of Neurology at the University of New Mexico. Here's Masoom.
Welcome, Dr. Gustavo Pradilla. Thanks for being here at the ANA Investigate podcast.
Thank you for having me.
Dr. Pradilla, for years, the standard treatment for intracerebral hemorrhage has revolved around medical management due to the lack of improvement in functional outcomes seen with surgical interventions. The ENRICH trial is redefining the field of surgical management of intracerebral hemorrhage. Can you start by sharing what motivated this study and what makes its approach to treatment so revolutionary?
What motivated the study was, as you defined, the lack of surgical benefit for all the clinicians that take care of these patients. When you are reviewing the neuroimaging and seeing these large hematomas, it is intuitive that removing the hematoma will improve patients' outcomes. But we had conclusive class 1 data that was coming from very well designed and executed trials that were published in The Lancet in back-to-back studies called the STITCH trials. And the STITCH trials evaluated conventional surgery using a craniotomy for decompressing the brain and evacuating the hematoma. And while there were some advantages in survival, there was no neurological improvement. And the guidelines of care were based on the results of those trials. A few years after the STITCH trials took place, the collaboration between neurocritical care and neurosurgery led to the MISTY study. The MISTY study evaluated thrombolytics as a solution, placing a catheter into the hematoma and then allowing those thrombolytics to lyse the hematoma over a few days. And the results of the phase 3 study, the MISTY 3 trial, were published in The Lancet in 2019. And unfortunately, those were also negative in terms of improvement in neurological function. There was, again, a benefit on mortality, but not improvement in function. So that motivated this study, was the signal that there were some positive things about evacuating the hematomas, but we really didn't have a surgical solution. And that first signal started with a prospective registry that we did. We were part of a group of 10 centers that participated using a new type of technology that we coined into a term called MIPS, which stands for minimally invasive parafascicular surgery. And what that means is that we use a group of technologies and techniques that are based on imaging analysis, selecting trajectories that are more aware and more cautious with the connectivity of the white matter, using minimal access ports, smaller footprint devices that are delivered into the hematoma with image guidance, and then using automated tools for clot evacuation that make that process more efficacious. And we had an initial experience across these preliminary sites that was very positive. And then we decided to put that to the test, and that's when the ENRICH trial was designed.
Thank you for that insightful overview. Building on this, I'd like to dwell into the specifics of how ENRICH trial stands apart from prior research. Can you point out the key differences in the study design methodology, and surgical techniques in the ENRICH trial compared to previous RCTs in this field that demonstrated equivocal benefit with regards to functional outcome? And what were the key differences in terms of the devices and these neuroimaging techniques that were used in the study?
The surgical protocol that we utilized in ENRICH required that you obtained a diagnostic CT and a CT angiogram to locate the hemorrhage. One key factor that was different from many trials is that we enrolled patients that presented with a positive spot sign. So if you had active contrast extravasation on the CT angiogram, indicative of active bleeding, those patients would have been excluded in all the other trials. We actually included those patients. That was one key difference. The next difference is that we access the hematoma using image guidance. So we would take those images obtained from CT, CTA, or MRI and load them into a navigation system that will allow us to triangulate an entry point and a location and stay true to that trajectory. The trajectory that we picked was also very different. In traditional neurosurgical teaching, you would access a hematoma through the shortest distance possible. But using all of the knowledge that we gather from things like the human connectome, the awake neurophysiology data when we do tumor surgery, we've really redefined what it means to be an eloquent area. And there are a lot of areas that were thought of as non-eloquent that we now know have substantial functions. So what we did is design these trajectories to the hematomas that were not necessarily the shortest distance, but were the most fiber sparing in terms of the white matter. So they were creating the least amount of disconnection syndromes among the different lobes involved. The next part that was different is that instead of cutting the brain surface, doing a procedure called a corticectomy, we decided to enter the brain through a sulcus. So we would open the superficial arachnoid and then use these ports that are 13 millimeters in maximum diameter. They start at 0.9 millimeters, and as the device progresses, it extends to 13.5 millimeters. So it's kind of a dilation of the white matter fibers, very much like the Seldinger technique introduces catheters for central line. And then once that port is in place, then the way we looked inside of the port was very different. Traditionally in neurosurgery, you use either a microscope, which delivers light over the target, or an endoscope, which is introduced into a cavity and delivers the light at the site of action. But there was a new type of visualization called an exoscope, which was able to deliver 100% of the payload in terms of light and magnification at the bottom of these ports, so we could see better. And then finally, the tool that we use to evacuate the hematoma is an automated suction and resection tool, so that no matter how fibrous the clot, we could get it out. And we put all of those components together. That's a completely different technique from everything that was done before. That's the surgery side. To the clinical trial design, that's another of the pretty substantial innovations about this trial. So our partners in the trial design was a group called Berry Consultants. And Berry Consultants have been the pioneers in adaptive Bayesian trial design. They were involved with the Dawn trial and with several other studies for thrombectomy for stroke. The ENRICH trial was not the first study to have an adaptive Bayesian design, but it was the first study to use the adaptation. So what that means is that we designed the study to have a sample size of 300 patients. When we got to a critical mass of patients of 150, our statisticians and our data safety and monitoring board did an analysis, and they determined if the trial had a high probability of success if we enrolled the two locations that we were studying. We were studying basal ganglia hemorrhages and lobar hemorrhages. And they would determine if the trial could be successful, enrolling both of those locations. And if the answer was no, then it would look at what happens if we only enroll lobar hemorrhages, or what happens if we only enroll basal ganglia hemorrhages. That was the adaptive portion of the study. And it would then trigger these adaptation rules. When we got to 175 enrolled patients, a rule for statistical futility for the basal ganglia location took place. We stopped enrolling those patients because it would decrease the likelihood of a successful trial, and we only focused on the lobar hemorrhage patients. So that was a pretty different, substantial innovation in clinical trial design to use these Bayesian studies.
That's fascinating. Can you briefly summarize the results of the ENRICH trial?
Yes. The primary outcome measure, which was the utility-weighted modified ranking score, was analyzed using Bayesian statistics and the posterior probability of superiority of the surgical intervention being better than medical management in the overall study was 0.98. So 98% probability that the surgical intervention had a positive result. Those results were driven primarily by the lower location patients. Those patients had a 99% posterior probability of superiority. That was the most important finding. In addition to that, we were able to decrease the length of stay in the ICU by 2.6 days. We were able to decrease the hospital length of stay, non-ICU, by 2.4 days. We had a significantly lower rate of serious adverse events in the patients treated with surgery. We also were able to decrease the number of decompressive craniectomies. It was 3% in the surgical group and 20% in the medical management group. Finally, ventilation days were substantially lower in patients that were treated with surgery versus the patients that were treated with medical management.
Talking a little bit more about the selection criteria, were the patients with CA or extensive white matter disease included in this trial?
Yes, so we did not screen for that. Our inclusion criteria, age was 18 to 80. So I'm sure we had some patients that had white matter disease in there. We wanted primary hemorrhages, so we excluded patients that had aneurysms, AVMs, hemorrhagic stroke transformations were those excluded. We focused on patients that had volumes between 30 and 80 cc, so large hematomas. We wanted GCS status to be between 5 and 14, so patients that were very much symptomatic but not herniating. And we wanted good baselines, so they had to have an MRS of 0 or 1. As you can imagine, there were many patients that were on antiplatelets and anticoagulants, and we enrolled those as long as we could rapidly reverse those. Towards the middle of the study, Andexa, which is the reversal for 10A inhibitors, was approved. So that was a nice thing that happened and increased that enrollment.
Thank you for shedding light into the selection criteria for the study. Should the surgery be offered to patients other than lobar hemorrhages, and how do you consent those patients in clinical practice?
That is a great question. For those who haven't had the chance to review the results of the study, we had 31% were basal ganglia and 69% were lobar. So we had a substantial group. And in the study design, the final outcome measure and all of the other secondary outcomes were done including basal ganglia patients, which is an important thing to keep in mind. So because we dropped that arm doesn't mean that we did not include those patients in the analysis. In other words, the study was positive despite having the basal ganglia patients in there. All of the devices that we use in the study are FDA-cleared devices for an ICH indication. So there was not a new indication study. These were all approved devices. And when we look at the results of the trial, if you look at how we represent the outcome is represented in the posterior probability of superiority. So for the entire population, the likelihood of a superior outcome with the surgical intervention was 98% or 0.98. For the lower population, it was 99% or 0.99. For the basal ganglia, it was about 0.43. So there were patients that were benefiting from the intervention, and there were patients that were not in terms of the primary outcome measure, the utility weight. But when we look at the other successes of the trial, we were also able to decrease ICU length of stay, hospital length of stay, days of ventilation, serious adverse events, and need for a decompressive hemicraniectomy. And those benefits also apply to the basal ganglia population. So in our interpretation of these findings, we see a lot of value in also treating basal ganglia patients. We're not saying that we're going to change their utility weighted modifier ranking scores at 6 months, like we did for the lobar patients. That remains an unanswered question. But all of the other benefits apply to them. So in our practice, in our institution, we are very aggressive with basal ganglia hemorrhage patients as well.
Let's talk about the generalizability of the ENRICH trial results. Given the specific inclusion-exclusion criteria, the need for the surgical technique and expertise, and the advanced neuroimaging techniques that were utilized for this trial, how applicable are the results to the broader population and to the centers across the United States and globally? I'm also curious to hear if these changes affect the workflow for transfer of ICH patients to surgically equipped centers.
We have 37 sites that participated in the study. And if you look at our sites, we have major academic partners that were involved. Hopkins was involved, Mayo was involved, UPMC was involved, but we also had community hospitals that were involved. And we did not see a difference in the outcomes between academic and non-academic hospitals, meaning the success of the procedure remained the same despite of your teaching institution status. And to us, that was a remarkable thing. And I think it is explained by the fact that the technology has been effective at leveling the playing field. In other words, you don't have to be a virtuoso surgeon to achieve a good result. So that's an important thing, that we can extrapolate the results being achievable in all of these locations. When you look at the number of surgeons that have been trained, the industry partners that we had, both Nico Corporation, which manufactured the devices that we used in the trial, but also the other supporting technologies that we use, they have been instrumental in educating surgeons internationally across the world. There have been more than 1,500 surgeons trained in these techniques. And there are continuous training sessions taking place. So as we expand on the training for this procedure, more and more sites will be able to do this.
As we consider how these results can be integrated into clinical practice, how does a future surgical management trial of intracerebral hemorrhage look like?
The next trial that we have already designed is going to evaluate basal ganglia hemorrhages. And we've always had this belief that not all hemorrhage locations behave in the same way. Any clinician that takes care of these patients knows that. For example, if you have a 75-year-old patient that presents with a 90 cc hemorrhage in the frontal lobe, that patient probably has enough brain atrophy that large volume hemorrhage is something that they can survive, and if treated within the right amount of time, they can recover from that. A patient that is in their 40s with a basal ganglia hemorrhage that is 80 cc's, it's very hard for them to overcome such an injury. Doesn't matter how young they are. It's a really high bar to recover from. thalamic hemorrhages are very different. Many of these thalamic hemorrhages dissect into the midbrain, and that membrane injury causes them to be obtunded for longer periods of time. Eventually, they can make a good recovery, but it's not within 6 months. It's more a year to see the full benefit of this. So these are all very different. So we're trying to move away from putting all ICHs under one umbrella and saying you really have to be nuanced and treat the lobar hemorrhages in the way that we've described it, the basal ganglia hemorrhages in a different way, and the same for the thalamic hemorrhages. So that's what we see the future of clinical trial design for ICH going, is to be very nuanced on the location and trying to identify what is the sweet spot in the selection criteria. Is it going to be time, so we intervene sooner? Is it going to be volume, so we use different thresholds for each location? So that's where these trial designs are going to go, is to answer these questions about timing, about location, about volume, and about treatment goals.
Dr. Pradilla, thank you so much for joining us on ANA Investigates and sharing your insights on this groundbreaking study and the future of surgical management of intracerebral hemorrhage.
My pleasure. Thank you so much for having me, and I appreciate the attention to this study, and hopefully many people will get involved and continue to transform the field.
That was Dr. Gustavo Pradilla, Professor of Neurosurgery, Otolaryngology, and Head and Neck Surgery at Emory University School of Medicine, interviewed by Dr. Masoom J. Desai, Assistant Professor of Neurology at the University of New Mexico. ANA Investigates is the official podcast of the American Neurological Association. The show's producers are members of the ANA Education Innovation Committee, chaired by Michelle Johansson. I'm Adeline Goss, podcast host and executive producer. Our program was produced today by Masoom J. Desai and me, with help from Caitlin White and Jen Hurley. You can listen to past episodes of the show, subscribe to us so you never miss an episode, and access all of the ANA's educational programs at myana.org. That's it for ANA Investigates. See you next month.